Hello and welcome back to the Ophthalmic Referrals series. My name is Christian, I'm an optometrist, and the aim of this series is to offer some helpful hints and tips to my optometry colleagues in primary care who are making referrals to ophthalmology. Today we're going to talk about cataract referrals. I would encourage you to watch the first video in this series as it covers the generic information which we should include in any ophthalmology referral. Please also remember that this is how I would process a cataract referral, and you must use your professional judgment and follow any local protocols and guidelines that may be in effect. Let's start off by talking a bit about NICE NG77. This guidance gives us a number of recommendations which should be followed before we refer a patient for cataract surgery. In general terms, they're talking about both oral and written instructions so that a patient understands what a cataract is and what the surgery involves. Specifically, we should be describing how the cataract is affecting the patient's quality of life in addition to their VA, whether one or both eyes are affected, the risks and benefits of surgery and what it entails, and how their vision and quality of life may be affected for those patients who choose not to have cataract surgery. If they don't want to have cataract surgery, there's probably not a huge amount of point in referring them at this stage. If you really believe they need to have the surgery done, then you need to clearly explain to the patient your reasons why you believe that's the case. But if they go through the process and then decline surgery, then it can be quite a waste of NHS resources. The guidance also says that we shouldn't restrict access to cataract surgery on the basis of visual acuity alone, and for a long time this was a problem where if they didn't meet VA criteria, they were not eligible for cataract surgery. But I would remind you that NG77 are guidelines, but it's the CCG, or as they're now known in many cases, the ICB, who actually pay the bills. They're the ones who set the criteria in your locality for NHS funded surgery, and they may well request a certain VA standard is met, certain quality of life metrics are met, or perhaps a scoring system. Let's start off with the basics, so what we would include in all of our cataract referrals. Cataract type is helpful, particularly if it's a posterior subcapsular cataract, because as we know that can really affect acuity and quality of life. The refractive error and the monocular VA are very useful, and we would of course include those in all our referrals. In terms of the effect on quality of life, it's good to give some concrete examples here. Is it affecting their ability to drive, to work, to become involved in leisure activities? Are they getting glare or dazzle? Are they at an increased risk of falls? Perhaps all of these things apply, and then you're putting together very strong evidence to justify having cataract surgery done. Make it clear that they're aware of the risks and benefits so that they're making an informed choice, and also that they would go ahead and have the surgery done if it was offered. What should we avoid in our cataract referrals? Do remember that if a patient has cataract and another eye condition, let's say for example glaucoma, in the great majority of cases the patient would go to the glaucoma clinic who would assess the glaucoma and then consider whether or not the cataracts need to be treated. If you feel that the cataract is bad enough that that really needs to be prioritised, I would encourage you to consider writing two separate referrals, one for cataract and one for the other eye condition. It's not that helpful to write, for example, in accordance with NICE guidelines, refer for cataract surgery, but then not to actually include the information that the NICE guidelines have recommended, those that we've just been talking about. To state that a cataract is affecting somebody's quality of life, but without actually giving concrete examples, is not helpful, and those referrals may well be rejected. And finally, in terms of urgency, the overwhelming majority of cataract referrals are treated as routine. There are some exceptions, and you need to know what those reasons are locally. Typically, it would be a patient who has significant anisometropia after having first eye surgery, perhaps at fall risk, perhaps a young patient who's no longer able to work. But because a patient has a social engagement in a couple of months' time, for example, having had cataract in their eyes for many years, it doesn't just suddenly become urgent. Once we've got the basics right, we can then look to upgrade our cataract referrals. The previous refractive error can be helpful, particularly in more advanced cataract. If a patient's been myopic all their life, then when the surgeon has the conversation with the patient about the power of the implant, and that information can be relevant. Similarly, historic VA can be helpful so that the surgeon knows the acuity potential of that eye. And pinhole acuity is, again, one of those standard measures that we'd usually include anyway. Are there reasons to justify cataract surgery outside of quality of life and visual acuity? So anisometropia is one that we've already touched on, and you'll find locally there may be a list of indications that can justify doing cataract surgery even if other criteria aren't met. And a common example would be a patient with diabetic retinopathy where the quality of their retinal screening is getting worse because of the cataract, and early cataract removal then can be indicated. Is this for first eye or second eye surgery, and is it for the right, the left, or both? And are there any comorbidities? So amblyopia is a common one, or macular disease. And if there is maculopathy, then it's very helpful to submit an OCT scan and a photo if possible. If they're a smoker, make a note of it, and where possible refer them to smoking cessation. And this can just be verbal advice that you give to the patient. And there are a number of things that can make the risk of complications during cataract surgery higher. Small immobile pupils, if there's pseudoexfoliation so that the lens zonules are weaker. Corneal opacity such as arcus will impair the view that the surgeon has when they're operating, and as you know, corneal dystrophies, especially Fuchs, can decompensate, and medications such as tamsulosin can make cataract surgery more complex. Thank you for watching this short talk on cataract referrals. Next time we'll talk about medical retina.